My name is Amberle Prater, and I really want to start off today, first of all, by saying I am so excited to be here in this area. I am actually from this area, so I love being here, being home, and advocating for our youth and our providers here in the area. What I'm hoping to do in the next 45 minutes or so is bring some of these topics home. So our keynote speaker this morning, Dr. Walker, talked about overarching themes, and I want to bring this back here to Appalachia, to our rural areas, and talk a little bit about that. Before I go into that, I'll give you a little bit of information about what I do, I guess why I'm qualified to talk about some of this. So my team is really a unique team actually across the nation. So we focus on suicide prevention from a research standpoint and a prevention standpoint. So we have world-renowned researchers that work in my team, working on lots of different topics around suicide prevention, and then they give us the research and we implement it. And that's what I do, is I go into, across the state to help schools and communities implement suicide prevention in safe and effective ways. And that's what my entire team does. We are a small but mighty team. There's 10 of us on the prevention side. There's many more on the research side, as you can imagine. But we are in over 250 schools here in Ohio implementing prevention at some level. So I'm going to talk a little bit about what some of the national trends look like currently. What we know, and we've heard this repeatedly today, that these trends in our youth, that rates are increasing. We're not seeing them decrease at the current point in time. And you hear things, you see things in media. It's not deaths, it's deaths of despair, it's deaths of children. These are people, individual youths that we are losing, and we don't want to be losing them anymore. We also know that hospitals are crowded. We know there's that mental health crisis going on, and sometimes we take young people places, and like we just heard, they're waiting, and we don't want that happening either. Our rates of suicide attempts, particularly by self-poisoning, rose by 30% in 2021 compared with our pre-pandemic rates. And then we also know that our special populations are increasing at astronomical rates. So Black, Native American, Indian youth, Asian youth, and our LGBTQ plus youth also have rates increasing. In Ohio, compared to nationally, suicide is the second leading cause of death. We saw some numbers earlier, this does come from the WISCARs, that nationally it's the third leading cause of death. We have higher rates here at home. And I'm going to talk here in the next few slides about why that might be, a lot of it having to do with rural and low resource. But we did see these numbers, so they've not quite caught up in Ohio Department of Health's numbers yet, so you'll see this goes to 2021, and those are preliminary data. What we do know from what's coming out from 2022, that these rates, we are seeing that line going back up. So I just want to point that out. It almost looks as if they're going down, but unfortunately they're not. Suicide rates are growing at a faster pace in our rural youth. And we know that the rate of suicide among our rural youth is 54% higher than that of their urban counterpoints. That's a big deal. So I want to also point out, so here in Ohio, this is looking at the percentage of what's considered rural in Ohio. And most of Ohio is what you see as kind of that dark blue. Most of Ohio generally is rural. But I imagine you don't think of Columbus in the same way that you think about Logan. So keep in mind that though we are seeing Ohio at large as a rural state, down here in Southeast Ohio, those kind of light blue areas, there's a lot more of those down here that would be considered rural. And I want to almost overlay that with this chart. So this is something that came from my research team. I have to throw some kudos out to them because I said, you know what, I really want a map of Ohio that shows me what those rates look like. So an individual on our research team actually pulled this together for me in the last couple of weeks because I wanted to be able to share it with you all. So this is Ohio youth ages 10 to 17, the suicide rates by county from 2017 to 2021. I know that key probably looks pretty small to you, but if you can imagine, the darker the color, the higher the rates. So we do see a lot of scattered areas, but we see a lot of darker colors down here in this area. I also want to point out that when we're looking at these numbers come directly from coroners, as was mentioned earlier, and a lot of times suicide rates don't get accounted for. So as I was chatting with the young lady who helped me pull this chart together and we were looking at the numbers, I said, you know what, that's my hometown. I know that rate's higher. And so there's a lot of things to consider when we look at this chart, and unfortunately, one of the facts is that these rates don't account for all of them. These rates are higher. I know we all just had lunch. That may be settling in, and so I want to do a little bit of interaction here. And what I want you to do as I bring this close to home is I want you to take a couple of minutes. If you're not from Southeast Ohio, if you're not from rural Ohio, that's okay. Maybe think about your drive-in this morning, what that felt like. But I want you to take a couple of minutes, turn and talk to the individuals at your table, and I want you to talk about what makes Appalachia unique, what makes your community that's in a rural area unique. What are the strengths? What are some of the challenges that you're running into? And so I'm going to give you just a couple of minutes to have a conversation about that at your table. All right. So I heard a lot of talking. I heard a lot of things going on. I think, being from the area myself, I could think of a lot of things. One of the things I did in preparation for this was I actually reached out to some partners I have in schools in this area, and we actually were also interested from my team in, we hear the challenges, but what are the biggest challenges and what are the strengths? We talk a lot about what are the things that are difficult or that are hard to overcome, but also what are the things that we can use to build off of. We talk about that all the time in suicide prevention. We're not just focusing on those risk factors and warning signs, but also what are we building in the youth to help them overcome those risk factors? How are we mitigating those things? And so I reached out, and I was very fortunate to have several of our community partners that are from the Southeast area respond back to me. And I took all of that information and I put it together, and hopefully this reflects some of the things that you were talking about. I'm sure there's more. I had a lot of responses, but these are the themes that came up for me. So there's a culture of family, a drive to protect, a lot of caring attitudes in the community and support for loved ones, a sense of pride. I am from this area and I am proud of it. And support. The community comes together, families come together, individuals come together to help each other out. With the community, we heard a lot about how students are really invested in helping other students, and I have to say that student presentation earlier, that was incredible. That's something that I hope you all are very proud of, to get something like that going here. A lot of schools are interested in that and don't know how to get boots on the ground to do that, so that's fantastic. But we're seeing that. There's a common awareness of others and a sense of desire to advocate. In addition to that, there's a survivor mindset. There has to be some level of resilience to be in an area where resources can be so lacking, and for some things to be okay, for programs to keep going, and for people to help find solutions when they're there. So these were some of the strengths, and I'm going to come back to these throughout the presentation because we want to keep these in mind as we're thinking about how we overcome some of these devastating statistics that we see. Now I'm going to talk a little bit about those challenges. So obviously resources, transportation came up a lot, just that geographic isolation. Things like telehealth that have really been intended to be something that improves access to resources, that's not always feasible in an area where you don't have cell phone service everywhere, and maybe Wi-Fi is satellite and it's just really spotty and it's not going to be effective enough to even pull up a video. So some of those things. High rates of stigma can be there in communities, that transfers down to students, the youth that are going through things sometimes. So I think a lot of times in some ways, especially now, our youth are sometimes leagues ahead of us with some of that stigma stuff. An outsider perspective that can sometimes make it hard to get new programs up and going or to bring in new providers. So a lot of people kind of talked about that in their responses. We want to bring programs in, but every time we try, somebody's asking a question or we're struggling to give that answer. Along those lines, a decreased acceptance of help-seeking behavior. We got to keep it in the family. We don't talk about people about these problems, and so then, it's really hard to get things up and going, to get people talking, to reduce that stigma. It almost cycles it, keeps it going. There is also a common theme that came up, the pressure to uphold restrictive norms of masculinity. So we know suicide rates for males are much higher and much lethal in the United States, and so that's concerning that, sometimes our male population may be feeling like they can't come forward in a more significant way. And then transition stress. So it's hard if young people are thinking about leaving home, leaving their nest, and family pressures that can come along with that can add to things like seeking help. And so all of these are things that we heard about. I'm imagining none of this is probably really shocking to you all because you're living it, you're dealing with it, you're hearing it all of the time. I'm going to talk a little bit here about risk factors that are specific to our rural areas. We do have higher rates of traumas, of adverse childhood experiences. I'm seeing a lot of head nods, so these are things that you are familiar with. Substance use rates are higher. There is greater access to means, particularly firearms. There is a thing such as firearm culture. I'm from here, it's strong. Hunting is important. Being able to protect yourself and your family is very important. We have to think about that within the context of safety when it comes to suicide, though, as well. Limited access to mental health care. I already kind of droned on that a little bit. And then there can be, in some areas, higher rates of negative views towards individuals of the LGBTQ plus community or people of color. And so that makes it really difficult if you fall within that community and you're living in an area where it's really difficult to feel like you're accepted. There's a number of studies specific to LGBTQ plus individuals. One of them in particular said that rates of suicide attempts for LGBTQ plus youth is 8 times higher than those of their peer counterparts. But if just one person is able to align with them and provide them support in a meaningful way, that drops in half. So that's just one example, again, just one study, but that's a pretty significant number and also represents why it can be so important to support youth of all different backgrounds. And then again, with our LGBTQ plus youth, so we know that nearly half in rural areas felt that they were unaccepted, like they didn't belong. So that's a pretty big number. Obviously, we see things like this nationwide, but the research is showing that it is higher in our rural areas. So making sure that we're outreaching to those types of individuals to make sure that they have that one person, hopefully more, but at least that one person that's able to support them. I'm going to kind of come back to that gun culture here for just a moment. So firearms are our most commonly highly lethal items. If you think about a firearm, you can't medically reverse that type of an attempt if it occurs. And so we're very concerned when we hear about those types of attempts happening or access to firearms when somebody's had suicidal thoughts or behaviors. And so not only that, but we also have medications, chemicals, ingestibles, and sharp objects. And sometimes our challenge in objects used for strangulation. And sometimes our challenge is thinking about how to restrict these types of items in our communities with our young people. And I hear schools that I work with talking, we go in to implement suicide prevention programming, and we're talking about a young person we're about to call home to talk with their parents. And it's almost like a chuckle. They're not going to put their firearms away. You're never going to convince them to do that. But we have to keep that young person safe. It doesn't mean, we're stripping anybody of their rights, but it is crucial. We have to keep that young person safe. And how do we go about doing that? Firearms are the most common method used in suicides. So this is from CDC Wonder, and firearms are used in more than 50% of suicides. Again, this is our most lethal item that a young person could choose to use. We at Nationwide Children's Hospital have been doing some work along with a number of different people to talk about how do we talk about safe storage. part of that has to do with the gentle assumption that people have firearms in their homes, and that's okay. We can have firearms in our home. It's our right. But when you have a young person in your home that is dealing with this, we need to also think about their safety. And so this is, one handout that was kind of developed to think about, we're acknowledging that all of these things are likely to be in someone's home, but how do we think about keeping that young person safe in a way that also meets them where they are? So we understand that these are important things to you, but we also have to think about how we store those. And so it's not just talking about firearms, but other lethal items that could be in access as well. And then just also encouraging that communication that's happening with young people. In the United States, gun culture is very prevalent, so it's a common reason behind owning firearms, and it can feel very empowering physically, to keep yourself physically safe and emotionally. It can be attached to the idea of being a good patriotic American, and it has been shown to be a source of identity and moral meaning. Those are important things, and we don't want to take those away from somebody, but we do want to think about how we safely store. So typically, when we're working with families, again, we're asking, how are your firearms stored at home? Not, do you have firearms at home? We don't want it to come across as something judgmental, because we're not being judgmental or intending to be that, but we're asking these questions, and these are important questions to ask if you have a young person that you're working with that may be thinking about suicide. So obviously ideal would be off-site storage, but there are alternative options such as unloading, storing ammunition separate from the firearm itself, things like that. But again, it's about collaboration. How do we not discredit somebody's identity, but also help that young person be safe? When we think about next steps, and so this is, where I'm going to kind of lead into talking about what are some things that we can do. We want a collaborative approach. There are a lot of schools in this area that are taking on these types of approaches, because it's not just about one entity. It's not just about schools making the change. It's about a bunch of people coming together to stop the mental health crisis, to make it better, to help our young people. And so in a lot of ways, it does start with our primary care providers, and that's only because that's oftentimes who hears this information first. If it's not coming from our school, these are our medical professionals that are hearing it. So we need young people to have access to primary care. We also need them to have access to support when it's needed. And we just heard in the speaker before me that's difficult, that it's hard to find that sometimes. But we also need to be embedding behavioral health, mental health services within our primary care offices, because primary care doesn't always know what to do either, just like schools sometimes don't always know what to do. So we need to make sure that these types of services are collaborative, that they are working together. And so to kind of recap a little bit of what I've talked about so far, some of the recommendations that I would think about implementing would be peer supports, things that we've talked about, engaging community members. Who are the trusted adults that young people are going to, and how do we make them feel competent and comfortable to be able to react to concerns as they're coming forward with them? I just talked a little bit about collaborative care, but we really need to be integrating behavioral health and mental health. And when we don't have those things embedded, making sure that there's resources there. And that sometimes is just about somebody reaching out to somebody else and having those conversations. I also mentioned telemedicine. This can be a really great opportunity for individuals who have access to the capability of doing telehealth. That means areas like this where resources may be lacking can pull on urban areas' resources. But a couple of things we know about that we have to be thoughtful of is there are some significant cultural differences, and so we want to make sure that telemedicine provider is able to work within those realms. But also, where are ways or what are things that we can do to decrease barriers that might be in place for connectivity, things like that. I know even with schools I work with where service is low in areas, we have one school in particular, and they have evenings set aside for young people to come to the school to have telehealth visits because they don't have a local agency provider that's able to meet their needs, and so they actually work with clinicians some from Children's, but some from kind of all over, and they provide that Wi-Fi linkage, and in some cases provide the device that's used, whether it's their Chromebook or somebody else's computer. So thinking about what are the creative solutions that we might be able to have to help with those services. And along with that, they do some transportation. Again, transportation is a huge barrier. Not everybody can do that, but sometimes, like we've heard, it just takes one person to ask that question to get something like that rolling. And then reducing barriers when we're able to. Are there things we can do to support transportation, access to connectivity? Are we thinking about those culturally appropriate services? There's lots of different things here, but socioeconomics, some people don't have insurance, and again, we just heard about this, that middle class. We don't qualify for things, but we also can't afford them. But what does that look like? How do we get resources and that infrastructure that's really vital to getting these things up and going? So that's kind of an overarching view. I want to bring this specific to suicide prevention and specifically to suicide prevention in schools. And we heard this earlier too with a previous speaker that really the focus on schools is because most youth are attending school. Oftentimes they're at school more than they are at home, especially during the school year. And so that puts schools in a really nice position to be able to catch as many youth as possible. Again, we do want to be creatively thinking about youth who may be at home, who may be online schooling, things like that as well. But we know that we're catching a lot of youth by working in schools. The idea behind effective suicide prevention is that you're increasing help-seeking behavior, that you're encouraging young people to seek support, particularly hopefully from trusted adults. Peer-to-peer programs are fantastic, but we need adults to also help support that. And then engagement, not just of school staff, though that's pretty important, obviously, but also our community. Are we working within the community to reduce that stigma, to help them understand why this is important and why we can be partners in prevention? So caregivers, community members, different groups that might be out there, things that we want to think about. And then we also want to think about what we're decreasing. We want to decrease student risk, right? We want that to go down. We want attempts to go down. We want thoughts and behaviors to go down, and we want resources in place to support that. And then we also want to think about stigma. Any effective suicide prevention program is going to work to reduce stigma because unfortunately in the United States, stigma for suicide is pretty high. It's high for mental health. It's even higher when we talk about suicide and throw that word around. This may happen less so in this room, but sometimes when I go to schools, I can physically see people cringe every time I say the word suicide because it feels uncomfortable to talk about, particularly sometimes in our rural areas. It's not true. It happens everywhere, but I do see that occur every once in a while. When we think about schools, we want to think about a number of different things that are being implemented to help support suicide prevention. So at the bottom, that green gear shift, adult gatekeeper trainings. So I don't love the word gatekeeper. We've kind of moved away from that terminology on our team, but it's the idea that the adults working with young people know what the risk factors are, they know what the warning signs are, and then they know how to respond to that regardless of what their role is. So we have to give them tools and the knowledge to understand what those things are. Then we need to do the same thing with students. They also need to know what they're looking for among their peers, and that's important because we also know that sometimes there can be a barrier for young people getting information to adults, and we can reduce that simply by encouraging students to do that and helping them understand why it's important, but also allowing them to support each other. Sometimes they think that's not okay, and we want them to know that is okay, but there's also a point where it's above your responsibility, and we want to make sure that you have the support that you need and that your friend has the support that they need. The other piece is screening. We can talk about suicide prevention topics all we want. We can encourage students to make those change, but we also need to be identifying those students that need further support. We don't want them falling under the radar, and so screening is a really important process. And anytime you screen, you also have to follow up. And so we want a system like that in place so that students aren't falling through cracks. Some students, especially our highest risk students, are students that may not have friends at school, may not have peers that they're able to reach out to, may also not feel comfortable talking to an adult, but they fill out a screening form and we can identify them and get them some support that's much needed. So these are our 3 key factors. And I'm going to add into this as well, so with our kind of adult training, we also want to be thinking about caregivers and community members because our young people are interacting in those realms as well. We've heard, if you're in a school system, you've heard a lot about House Bill 123 over the last few years. It is actively in place and it is an expectation that all schools across Ohio are engaging in suicide prevention and other risk initiatives. And so, and our team were like, yes, this is great, schools can do this. But not all schools had the infrastructure in place to be able to do this. So we had a lot of panic schools calling us in August saying, what do we do? How do we get this up and going? And so we've done a lot of consultations across the state on, what are the programs in place? How do we implement something like this, and what does it look like? And a lot of times it's just a matter of like we see this list of programs on the HB 123 website, and we don't know what to do with this. And so, I'm going to break that down for you a little bit. So anywhere you see an asterisk, that is a program that's endorsed by House Bill 123. That means it meets the criteria of what they believe to be an effective program or a program that meets their minimum qualifications. I'm going to talk more about SOS, signs of suicide, because that is the one that we have utilized on our team. Our team really came about in 2015. At that time, there had been a cluster of suicides across the state of Ohio that had happened. There was a very unfortunate suicide cluster that had happened, and the hospital said, we've got to do something about this. And so they initiated our team. Our team came together, just a couple of us, and really dug into the research, because especially at that time, the research was pretty lacking. There wasn't a whole lot out there, and things were just starting to come out in relation to this. And so when we dug into the research, the program that stood out as gold standard was Signs of Suicide, and it continues to be that gold standard here in the United States for suicide prevention. So that was the one we grasped onto. We took that program, we actually enhanced it, and we work directly with the developers who are MindWise Innovations when we go into schools to implement this program. They actually pull a lot of their resources from us at this point, which is pretty cool. But one of the key things you'll see here, so this chart in particular, these are programs that have established an evidence base, meaning they've got peer-reviewed articles. There are articles out there that show, that demonstrate it's been proven to be an effective program. So Signs of Suicide, at least currently, blows a lot of these out of the water, and so we're proud that that's the one we've continued with. You also see QPR, Question, Persuade, Refer. That is a school-wide training, oftentimes with the adults. It doesn't do programming with the youth specifically. The PACS Good Behavior Game, we heard a little earlier about how important it is to focus on our young children as well, and that's what PACS does. So it's an elementary-based initiative for behavior management in youth. What we do know from their peer-reviewed articles, though, is that there are some positive outcomes for suicide as a result of PACS. So oftentimes you will see schools that actually improve suicide risk in their young people simply by implementing a behavior-based program. And then the last one we have here is YAM, Youth Aware of Mental Health. So this is a program, it started overseas, it's just kind of trickling over here. Actually, Dr. Walker worked with that team previously in Dallas, and they're doing some research here in the United States to really enhance their outcomes that they have. Our team got trained in this a couple of months ago, and we're doing some piloting with schools to kind of see what we think. It's a little different from SOS, but it does do a really nice job with suicide prevention, and it's more youth focused, so it's more based on each classroom kind of developing a culture of suicide prevention. The next chart you'll see here, these are programs that on our team we can consider to be supplemental suicide prevention programs, largely because there's a lot of limited outcomes, if any, for them. Again, all of these I pulled directly from House Bill 123's website, so these are all endorsed by them, again, as minimally qualifying for what their needs are. Sources of strength, it can be a little confusing. They also call that SOS, but it is different. It is student-led with a staff advisor, and it really focuses on a target group. It is student lead center, and you'll see for Hope Squad and Sources of Strength, both of those are student lead centered. That can be great. It can also sometimes be problematic depending upon how the advisor chooses those students. What we've heard just in kind of rumbling feedback is that sometimes the students chosen can be intimidating to go to for peers, and so you really have to think about how you're choosing students to be these peer leaders and what that looks like. That said, both of these have been really great supplemental programs to schools that are doing SOS, just to kind of meet students in a different place from that peer-to-peer. Erica's Lighthouse and Sandy Hook Promise are also, both of those are student awareness programs, so they have some kind of general information. There's no screening, there's no kind of overarching trainings for staff, things like that. And it really just kind of focuses on general topics around these. And Sandy Hook in particular, it doesn't even just focus on suicide prevention, it focuses on risk in general, so it talks about other areas of risk. So I'm going to talk to you a little bit about SOS and why our team has really focused on this. Again, it is evidence-based. One of the goals of the program is to teach students to teach teachers what their action steps are. You'll see that acronym down there, Acknowledge, Care, Tell, Act. That's what we want them to do. We want them to get information to a trusted adult. The program does, in my opinion, a nice job of breaking down barriers to that. It gives examples that include, what if my friend gets mad at me? If I talk about these things, or if I tell somebody what's going on. It addresses that head on. It talks about things like self-injury. It talks about social media. It talks about celebrities. It does a really nice job of breaking down some of the stigma that's out there related to suicide prevention and really engages students in that. Oops, wrong way. In addition to that, these are all the components that go into it. Now, I mentioned earlier that our team has enhanced SOS. If you go to SOS directly through MindWise, a lot of these components aren't built into it because we've enhanced them. They do have resources for each of these, but not necessarily are they specifically offered. So our team does kind of an initial engage and planning. We do that all staff training, and when we say all staff, we want it to be a PD day. School shut down. It doesn't have to be a PD day, there are other options for that, but we want everybody there. We want bus drivers there. We want cafeteria workers there, librarians. Any of those individuals can be a trusted adult for a young person. And so we can definitely, and we do want all teachers to be there, but we want those support staff there too whenever able, because they could be that one person that a young person would go to, that they would share this information with. And we want to make sure it goes to the next place that's going to be most helpful. So we also provide caregiver trainings. Again, I talked about the importance of not just engaging the school community, but in any opportunity that we can engage parents, caregivers, community members in understanding this information as well. And then we do some trainings to lead up to what we call a student rollout. That's where we're actively programming with students, and that program includes presentations to students, which talk about risk factors, warning signs, how they can respond. They engage in discussions, they watch video clip examples, and they talk about a lot of these things, and then they get screened. So we do a screening for suicide risk and depression and do a triage process for follow-up. And that triage process also includes implementing risk assessments. Now, I see a lot of faces out here of people that I've collaborated with. And so I thank them, because we have a lot of agency partners here locally that help us. We have a lot of school partners. I'm coming back next week here back to Logan to do their all-staff training. And these are things that don't happen if somebody doesn't say, hey, let's get this up and going, let's save lives. And that's what this program does. Nationwide, SOS reports from their studies a 64% reduction in suicide risk, which is specific to attempts after a school goes through the SOS program. With our enhanced components, we actually see that rate much higher. This is just to give you an idea of what the SOS program kind of looks like. You've got some video clip snippets there. There are resources for parents, so we do utilize some of the SOS resources in addition to the ones that we provide ourselves. We provide live caregiver trainings, but there's also a lot of really great resources. So if parents are asking, what is my kiddo about to go through? What are you doing with them? They can go here and they can watch snippets of the video clips. They can really engage in the content. They can see the screening form, those types of things to hopefully help them feel more comfortable with next steps. When we think about this, we also want to think about staff support. So we're asking staff members to make changes to think about suicide prevention within their realm. And so a lot of times we get the question, okay, what can I do? I'm not somebody that can do triage. I'm maybe not somebody who's selected to do a presentation with students. What can I do in my day-to-day? And these are some of the things that we recommend. So there's regular check-ins, validation, and then our encouragement is always, if they identify risk, that they immediately get that information to the next level of contact, a school mental health provider, an administrator that can follow up further. And so these are some of the things that we want staff to feel empowered to be able to do. It's okay for young people to talk about these things with them, but we need them to have some support in place too. A lot of that is, what are my next steps? And then obviously also some self-care as well. And I mentioned this already, so this is what we provide to staff members and what we encourage them to do, to supervise that student until they can get that next person who can follow up with them. We do recommend an escort, that they're not walking down to the office or wherever that space is on their own, and that they make sure they pass off information. So we're not keeping secrets for students either. You can be a trusted adult and still know where the line is for risk and need to pass that information off. For our team, so this just goes to 2022. I didn't throw in 2023 because we're still finishing up 2023. You can see here, this represents our school rollouts. So I mentioned to you earlier that we work with over 250 schools. And so these numbers are, you'll see in 2022 we had 91 schools. So the additional schools that we're working with are consultation. What are the policies in place? Maybe they're a sustaining school. And sustaining is what we're working towards. We're not coming in to step on toes. We're not coming in to take over the program. That's not what's going to make it effective and long-standing. We want to give you a program and then give you the ability to own that program. So a lot of the schools we're working with are schools that are past working with us actively, and they're doing a lot of consultation and planning, updated trainings, things like that. So you can see there, when COVID hit in 2020, our numbers dropped, but we still rolled out with 63 schools that school year. We had a lot of very unique things in place to keep everyone safe, masking, all that good stuff that, we hope is a thing of the past. But we still had that many schools that were able to move forward with programming. And now we have a lot of schools that weren't able to do that during COVID, and they're reaching out, hey, can you help us reboot? Can you help us get things up and going? And so we're happy to do that as well. And so we're working with a lot of schools to do some things like that to get it back up and going. So this is kind of our bragging point. So our team started, as I mentioned, in 2015. We had our first rollouts with schools. And so through June of 2023, we've had 229 school rollouts. We've worked in over 3,000 classrooms, and those student numbers there are lives that schools have saved. So we have had over 74,000 students go through the program. Of that, we've done over 20,000 triage assessments, and triages are done with students who have indicated some level of risk for depression, for suicide, sometimes for other concerns, or who are coming forward to refer a friend because they're concerned about a friend. And then of all of those, we've done almost 2,500 risk assessments of students who, so risk assessment is only done when a student has indicated suicide risk. They are having suicidal thoughts or they've had a suicide attempt in the last year. That's a lot of students. and then 382 crisis referrals. And it's important to note here too, one of the things I think are often misunderstood is that a young person in crisis definitely needs to go to the hospital, and that's not always the case. If we can get a good safety plan in place and we can send them home safely with parents aware of safety precautions, that's the ideal situation. If a young person doesn't need to be in the hospital, it can be a traumatic experience. So part of what the program aims to do is to reduce that. And to really make sure young people are ending up with the right level of care for what their needs are. This is just to show our growth over time. You can see we're really focused on this area and bringing the programs here. You can see we're pretty saturated in Franklin County because that's where we started. But we're more and more coming down to this area, which is fantastic. Some of the concerns we run into, and we hear these repeatedly, and we are still able to do some safe and effective programming with consideration for school culture, the needs, nuanced circumstances. It might be vamping up resources, it might be figuring out some creative solutions, but resources for follow-up comes up quite a bit. We're still able to program. We just have to think about what that looks like. And schools will say, well, we identify all these students, and then what? You're only here for the rollout, then what happens? And so, we're creating an infrastructure in collaboration with the school. There's also a lot of concerns for stigma. Challenges that we run into are related to sustainability. You want to think about when you're implementing a program like this, how do you keep it going? You have to maintain it. You have to think about it. Each cohort of students that comes through looks a little different, so programming looks a little bit different. And make sure that your quality isn't fading over time. Cost and resources sometimes comes up. I'll throw out, if you're from a school here, everything that we do is completely free of charge. You never see a bill from us for SOS. So that's pretty incredible. And so my recommendation would be, if you're coming from a school that doesn't already have something like this in place, let's get some collaboration in place, whether it's us, whether it's another local agency, but we have to take that step forward. We have to take those steps and do the things that we know are effective. And then continue evaluating. There's a lot of staff turnover. Trainings only sit in our brains, from what research tells us, for about a year. And then it fades away, and so we want to make sure that we're getting, at least biannual staff trainings in place for this type of information. Again, giving them the tools that they need to be successful. And that's true for agency providers too in the community. When you're kind of rolling with certain issues, and then maybe this isn't coming up as much, or maybe there's new information or new research out there, we want to keep engaging in that and keep our brains fresh. But your big takeaway, what I want you to take away from this more than anything, is that suicide is preventable. We identify a lot of risk when we go into schools, a lot of students who are having thoughts, but we also save a lot of lives. We catch those students, we get them the support that they need, and we help schools take that next step to maintain that. And so I'm going to end here for my presentation. Thank you all so much.